everyone excited, energized, ready for some action? 90 minutes of action, that's what we've got right now. You ready for it? So, someone obviously had too much coffee this morning. So health literacy, why is it important? I've actually really enjoyed having a look at all the information that sits behind health literacy, and there's a really fantastic resource that I've provided on the very last slide that you guys can take a photo of, which is in New South Wales, and there's a fantastic health literacy resource that you can go and have a look. There's health practitioner resources as well as community-based resources as well, and they've put a lot of time and effort into that. So I've utilised a lot of their stuff today because it's just so fantastic. Why wouldn't I? Understanding what it is, why is it important? I guess for me, I always come back to that analogy of just because we know doesn't mean that we do. And we've talked about that a little bit this morning, haven't we, about the barriers? What do people know about the reasons to have a cervical screening done? But does that mean that because they know the facts and the figures that they actually then take the next step and do? And that all comes down to human behaviour. Yeah, we've got a lot of reasons to resist doing something like that. And we've talked about particularly, you know, around the fear base, particularly if there's been a sexual assault or there's been some sort of abuse or something really horrible's happened to them. We talked a little bit about that in the morning tea break. You know, those horror stories, you know, we've all each had one, I've got no doubt, where you go and you have your pap smear done, next minute you're going back and having it repeated, or for some reason some horrible event happens to you during that. So of course, you know, you might go next time, oh, no thanks, or you might find an alternative. So the human behaviour side of things is really important. So health literacy we're going to have a look at as a starting point, and then we're going to step through how do we get through to someone. So giving them the information, which is the literacy, is one component, but communicating is actually connecting and getting through, and that's really key. So the two sit really nicely together. So hopefully after today you might just have a few more tips and tricks in your tool belt that you can take away, and I'm sure you guys, particularly working in this space, have many tips and tricks already. So what is it? The World Health Organization, so the ability of individuals to gain access, to understand and use information. So understanding's the key word there, understanding. Now AFRA have on one of their most frequent complaints to them as an industry that patients didn't understand what was expected from them or what was going to happen to them. So it's a really key piece, isn't it? Understanding. So we have a lot of assumptions because we have our own communication. We understand the lingo. We've been trained in the lingo. So for us, it's very familiar, but to common consumers, is it? And then to use the information which to promote and maintain good health. So I think getting that information out there in those Women Health Weeks are really important, aren't they? Because it does really put it back in everyone's, you know, profile, whether it's on media, Facebook, or whether it's on TV campaigns. Things like that really bring about, oh yeah, I haven't had one of those done for a while. It's really important. I can see why I need to go and have that and prioritise that again in my health. All right, so these are some good little stats, and it came from the American Journal of Obstetrics. Poor health literacy is a better communication of low cancer screening, better predictor I should say, rather than ethnicity and knowledge. How's that? I don't kind of know where to stand, Gary. I'm going to stand here. Individuals with low health literacy obtain less information from cancer control messages. So this is important again, isn't it? You can communicate it out, but where's it actually hitting? Where's the target audience? So you might need to use lots of different media streams to hit lots of different literacy levels. And also, we also look at the materials and the conversations that we're having. So I feel that nurses particularly have that timeliness and also that intuitiveness to really make sure that we're hitting the mark with having those really key, subtle conversations. So you, as you highlighted earlier on, it's taken you 2 or 3 appointments before anyone's touching anyone. Yeah, sometimes, as we said, Joe said, it's about the pace. All those kind of things are coming from your gut, aren't they? The intuitiveness and when the right timeliness is there. It's not I made an appointment, something happened to me that I felt really uncomfortable with, and then I got a result in the mail. Sometimes it takes time. And knowing, again, is there an appropriate women's health clinic that someone else feels really comfortable to go to? So I spoke in the tea room before about, I'm a consultant working with lots of GP practices. I don't want to go there for my pap smear. So I will go to a women's clinic where I feel like that's a little bit of ease. But when I was working in a medical centre, I felt more than happy to go to my female GPs or my colleagues. It's just a little bit different. So we've got to consider those sorts of things as well. Here's the key piece. Health professionals rarely recognise low levels of literacy. Why? Because it's hard to assess, is it not? And people have a lot of pride. So they're not going to really self-identify that I can't read that. So for instance, I had a chap who was really quite obese, and I was working with him on a coaching context, and for ages we were giving him lots of literacy around his diet and exercise, lots of different formats, so go share using videos, all sorts of things. And it was finally until about the 6th or 8th time that it clicked, and he watched a Michael Mosley episode, so he saw something that he connected with, which was about gardening and the soil in his gut, and he went, oh, that makes sense to me. See where he's really utilising his passions to connect the dots. And he came back to me with a list of all the things he'd eaten. I couldn't understand one word that was on that page. I had no idea this guy was low literate. If anything, I'd say is nearly illiterate. And I said to him, you read what's on that page and I'll look it up, because he wanted to know how many macronutrients and micro, and I'm like, I don't know. So he goes, carrots, and I looked down at the word and I thought, that does not look like carrots to me, yeah? So how do we screen the communication that we're delivering, the information that we're giving to the right literacy level? Improved physician awareness and the development of low literacy interventions may improve. So this is a key component, isn't it? It may be something that you're going to do moving forward, having that insight into what is being a barrier to get, we've got the people that are going to be coming along and having their 2 or 5 yearly screening done. What about the other ones? How are we going to snare them in? How are we going to engage them? So this is the pieces of the health literacy puzzle. So we've got the place where the healthcare is provided. We now have well women's centres, thank goodness for that, I say. And then we have the people who provide the healthcare, so you guys as nurses in there delivering that face-to-face context. And then the health information, here's the key words again, that makes sense. Again, just putting that lens on, do we understand it because this is familiar to us versus the consumers out on the street? So here's a great visual tool that looks at what kind of information can we impart. So we've got written and spoken information that's clear and easy to understand. Not a lot of words, that's important. And the key points at the top. So someone like me, you've got to get me within a couple of seconds or else I tune out. So what is it that you want to tell me that's super important for me to go and have my cervical screening done if I'm in the treatment room having my influenza shot? Because it's come up as a reminder and recall that I'm overdue by 3 years. What are you going to say to me? How are you going to go, Kim, I saw on your reminder and recall that your pap smear is overdue, and I go, yeah, no. What are you going to say to me?
Important, safe and sensitive care.
Great. So important because?
To your health and well-being.
Great. And safe.
Safe, the service is safe and comfortable environment for you as women to attend.
Great. And what was the other one?
Sensitive.
And sensitive.
And then the details, who to contact, where,
Yep.
and who's eligible.
Yep. And I might need those captions in the weight room so that when I'm hanging around, I see it. And then when I come in, Jo's with me and I'm having my influenza, she says those 3 phrases to me. And then I go out to pay at reception and it might be out there as well. Why? Because the RACGP guidelines say that we need to see things often 6 times before we actually take it in. So it's important to have it lots of places. So that's why sometimes, we feel like we're repeating and repeating and repeating and prompting and prompting and prompting, but it's important to know then we don't just necessarily comply first time round. And then we have information alongside consumers that needs to be culturally appropriate as well. So last week when I was speaking in Ballarat at the MBS and triage workshop, they had a lady come along who was working in the refugee centre as well, and she said whenever you can offer face-to-face interpretation services as well. So yes, it's okay to have the hotline that you can call, but if you can get that face-to-face, schedule the appointments so someone can be there as a representative, that's fantastic as well. So places where the healthcare is provided needs to be accessible. I think Rivka covered that in terms of disability services, making sure people can get in, easy to find and get around. We have policies and systems in place that encourage health literacy. Who's got a health literacy policy and procedure? You guys got one?
Ours is broader than that, it's more about information.
Generally?
The ways that we would provide the information and what that would look like.
Great.
But we do run our documents where we can through one of those health literacy assessment tools. So something I was working on the other day was level 9, which is unacceptable.
Great.
It's level 6 or below. And that makes you really have to revise who you're writing that for.
Excellent.
And
And what platform did you use?
I can't remember what it's called. There's several of them.
Flesh Kincaid or Gobbledygook?
Flesh Kincaid I used before, but this one was a different one. I can't remember what it was. One of my colleagues found it.
Yeah.
But it was really useful. You just cut and paste what you've written into
That's it.
and it works out where you've gone wrong.
Perfect. Simple and easy, hey? This is what I want to say. I can run it through and I can actually come out and it can hit the right audience and the right literacy level, which is really key here. I'm going to show you them. Yeah, I didn't say them that quick and leave you high and dry, let me assure you. All right, and have leaders who advocate for it. So it's super important, isn't it, when we're thinking about under-screening, particularly in things that are preventable. We can look at it in terms of our chronic disease management systems as well. We can think about it in so many different levels, can't we, in terms of where we are in primary care. So it's really important to think about who is engaged but who isn't engaged and what's the reason for it. Maybe it's the way that we're sending the messaging out. Can we tweak and adjust that? The people who provide healthcare, so we're going to talk about teach back. The respiratory nurses in the room or people who have done diabetes education might know of teach back already, but teach back is when you're starting to show a client a new way of utilising a piece of equipment, even blood pressure, home monitoring, that kind of thing, and then getting them to demonstrate back the steps, because we know that that's a better way of getting them to uptake the information, but also to demonstrate to us that they've understood that information. Where are the gaps? Because I tell you what, they'll nod and they'll go home and goodness knows what they're doing, and it's not until they're explaining it later on. So mum's had cancer and she's like, oh, this is what's happened in my appointment. And I'll go, none of that makes sense. That doesn't connect with that, that doesn't make, So we've also got to understand that people in that tense environment of hearing lots of information, what's their interpretation of what just, and then they go home to their family members and tell them what. because seriously I have to ring her GP and go, I don't understand one word of what she just said and how that all fits together. And he goes, well, that matches that matches. It's putting the pieces of the puzzle together for them, isn't it? Providing that person-centred care. So what is going to drive that human's behaviour? Think of that. So when we're thinking about generic people who come in, they see the campaigns, so they go, yes, I need to do that because I understand it's important for my health. Think about smoke cessation. Did that campaign work when people knew that it was bad for them? It wasn't until they put the increased dollars and cents, people went, oh, I might give up smoking as a consequence, not because of the health messaging that went behind it. Doesn't necessarily drive behaviour change. Okay, so it's really important to think about what is important for that human being that's sitting in front of me, and that's why I think it's really great, particularly having nurses involved in this, because you're going to find out what makes a person tick. What do you know about that person that's actually going to be important for them? Quality of life pieces here that's going to drive their behaviour to go and have that done. Okay? And complete health literacy training. So again, this resource that's on that New South Wales site, you can go and undertake all of this online, which is fabulous. What do we know? 60% of Australian adults do not have the level of health literacy. That is a big stat, is it not? Boom, 60%. We have all these assumptions because we understand that everyone else understands, don't we? And then 40 to 80%, see Mum sits in here, doesn't she? What do they take away from that information? Think of hearing deficits. That's one of the main reasons why she doesn't connect all the pieces right. She only hears bits and pieces of it. So she takes Dad, who hears the other bits and pieces, and together they come up with quite the conspiracy story. So we need to make sure that we're really looking at how that information is being perceived and understood, so getting them to explain back what we just shared with them, and then filling in the gaps accordingly. Some factors that can affect it, as I said, deficits, so hearing, visual, people getting a little bit eye deterioration and, like me, not wanting to wear glasses. So age, culture and language. We're getting quite diverse, aren't we, in terms of our multiculturalism. Education levels, we can't just assume that everyone did the stock standard going through year 12 or up to year 10. Overseas, they may have only gone, to primary level if they're lucky. Socio-economic status, so again, those low pockets in the community can really impact compliance and adherence. Disability and health context. All right, so there was a health literacy, so yeah, Jo.
I was just going to say, I think health context, particularly in our area, is becoming more and more an influence on people's health literacy.
Tell me more about that.
So I think we're probably all seeing increase in mental health challenges.
Yeah.
If you're homeless, cervical screening is probably not
low. Yeah.
So it's then how to overcome those challenges to support that person to consider that other aspects of their health are priorities.
And that's a really fantastic point, Jo. So the psychosocial impacts need to be addressed first, don't they, before we can talk about self-management, which this sits really in amongst, isn't it? There's a fantastic resource that I'll put on Basecamp, and there's free social determinants of health webinars going on at the moment, so I'll pop that on there, and it's fantastic. You can stop and start it. It goes for about 90 minutes, but they've got panel discussions with people from mental health orgs. They've also got Aboriginal health workers, etc., talking about what can be a barrier for people doing that self-management piece. So here's a health literacy survey. It started in January 18 and went through to August 18. HLQ is a health literacy questionnaire. There's 44 questions that's encompassed, and this was done through Deakin University. So Deakin University had a look and screened and found 1/3 of Australians found it always easy to discuss their health concerns and actively engage. 56% found it usually easy, and 12% found it quite difficult. Overall, 25% strongly agreed that they felt socially supported. However, here's the big one, isn't it? And we know that that's just ever increasing over the age of 65. With 3 or more long-term health conditions were less likely to strongly agree. So this is a fantastic, again, you can have access to this resource to look at what do we need to, in terms of when we're considering sending out information, what do we need to do? We need to make sure that we have it accessible to all screening messages, provide information in formats, so print, video, email and text messages. So again, this comes down to that communication type and style that we all like. Think about yourself. How do you like to learn? Do you like to learn by reading things? Me, not so much. If you give me pictures, I love it. I'll stop and look at something, particularly if it's got pictures associated with it. What about a video? Yes, we've seen that a lot of the education materials are now in that cartoon style explanatory video, isn't it? And it's usually just short and punchy. So a couple of minutes is about all you're going to keep people engaged in that communication. Can you send it out so it's getting your target audience who aren't necessarily coming through your doors? And text messages, really powerful now, isn't it? Hot docs, set a spray out to all your clients as a reminder and recall, rather than having that labour intensive of, I can remember getting the reminder and recallers letter, picking up the phone, calling each person individually. They didn't answer the phone, then we've got to send them out, you know, that priority letter, all of that, huh? So it's labour intensive on your staff. Distribute messages in a variety of ways. So lots of practices are now got a social media presence, haven't they? So that's been really fabulous as well, particularly highlighting things like Women's Health Week. You know, we might have another mental health week. There's always weeks now, isn't there? So it's a great way to really get some activity and promote those in-house things. And I really love what you're doing, Gabby. I think it's fantastic to really move it and shake it and be a bit creative with it. And you know, you guys getting out there and doing your evening, was it evening or weekend, Joe? 2 evenings. And have such fabulous attendance of actually getting people there. That speaks volumes, doesn't it? And Cardinia Health have health information nights where they'll spray it out to their social media page and say, we're going to have someone talking on stress and sleep, etc. come along. So it's always well attended. Think about who, where, when and who you're going to try and provide the information to. So again, thinking about the people that aren't coming, less so than the people that already are engaged. Make information clear and understand. Drop the jargon and use plain language. We're going to look at that a little bit deeper. Make recall and reminder letters and text messages easy to read. And if you're unsure, well, there's these fantastic resources that we're going to show you. Provide information, what's important. How much is it going to cost me? Can I even afford it before you even tell me any more? And I think we sort of talked about a little bit more about that earlier on in the morning tea session around how much are we expecting patients and consumers to do in terms of travel, organisation, all of those key components. So we were talking about Amanda having to go down and have either a private procedure or a public procedure, whether or not she drives 65 kilometres to pick up paperwork, or is that just ridiculous? Can we give it to her in a way that means that she doesn't have to take time out of her work schedule and her life for 3 hours to pick up paperwork? All of those really key things around what can be quite the barrier. So working women, you know, they are in a big chunk of that age group, 25 to 74. How many years potentially are women working for now? Up to 65, some are around there at 70, aren't they? And if you're going to be like me, I'll be doing every activity because I'm so jealous that they get to play mahjong and have fun. All those cool things that they do. So how am I going to fit it into my schedule to come? So I want to know how much it's going to cost me, how long am I going to be there for, How long are you going to hold me hostage? Because I don't like being at the doctor's. I only want to be there for a short time. And I don't want the doctor making me late either, because I've got an important place to be. So I know the nurse is on time. I'm going to go to the nurse. She's going to have me in and out in how long? 20 minutes? 15 minutes? That's all important stuff to impart in your messages, isn't it? Be clear on that. And then what are we going to do? What's the screening guidelines? And then follow up. So that's kind of your key punchy things, aren't they? It's going to cost you this. This is how long you're going to be there for. This is what's going to happen. And this is what the follow-up's going to be. Is someone going to ring me, or do I have to ring you guys? Yeah. Or do they ring reception? Reception go, I don't know. I can't tell you that. Appraise. Help people understand, get the targeted messages out there. So who is actually coming through our doors, and what kind of cultural or literacy levels do I need to be speaking to, or what kind of considerations need to be there. And then we need to act. Support informed decision making and provide decision aids, which is what I'm hearing with you guys around if there has been an assault, that you're starting to think about what else can we do to support that woman moving forward. Okay, so plain language checklist. Are you ready? Hold on to your hats. Have I replaced the jargon with language people can understand? Because we use jargon all day long, do we not? We love an acronym in the healthcare system. We have our own way of talking. Are any technical terms explained? We know what that means, but do they? Have I given the most important information first? Am I going to read on? I don't want to find out the most important piece at the end because I missed it. I've just read it and gone, not information I need or want, and put it in the bin. Have I used lists and headings to make the information clear? Short, concise and succinct is always best. Have I asked my intended audience, now this is a really good thing to do, to read it and to give you feedback on it? That's a really good piece. All right, are you ready? This is what's called the Suitability Assessment and Materials Score Sheet, and we're aiming for a score of 10. If you can tick 10 of these things, you know you're on the right track of making sure that you have, why have we got that across there? To make sure that it's nice and easy to read. So write the text at grade 6 to grade 8 level, and we're going to show you where those tools are, because I would have no idea whether it's at grade 6 or grade 8 level without that information that I can throw through an assessment tool. Use plain language. Align blocks of text to the left. Use one font for the whole document, so don't change and make that font bigger for the heading and that font lower, yeah. Use font size 12 or bigger. Important information is bold, no capitals or italics, because that gives a tonality to words, yeah? Clearly state the purpose of the resource, main points appearing first. Write the main information about the desirable behaviour, having the cervical screen, rather than when you don't have your cervical screen, this can happen to you. Fear-based language doesn't drive behaviour. Include only essential instructions and information. Use words you, we and us instead of patient, hospital staff. Make it so it's about them, they feel part of it. Small chunks of text, include pictures. You know I'm going to read it if you put pictures in it. Make sure there's plenty of white space on the page, and test the resource with at least 5 consumers that are culturally appropriate. Good stuff, huh? If you can tick 10 of them, you're on the right track. This is the assessment tools that you can find in Microsoft Word. One's called Flesh Reading Ease, and it'll give you the grade level. And I've got the steps there. As I said, this is going to go on your resources, so don't write all these down. That's just a lot of stuff and a lot of work for you. And the other one is gobbledygook. Don't you love it? So it calculates the reading grade on 2 factors, the number of syllables in the words and the number of words in sentences. It's clever, isn't it? There are a range of online tools that you can find out your readability. There's one also called the Hemingway Editor app. Is that the one you use, Joe? which checks words, sentences, as well as active voice and strength of your phrasing. I think that sounds good.
Yeah, we use passive phrasing in a couple of places and a picture on that. So.
Great. Did it give you suggestions on your passive?
Give some suggestions, yeah. And it colour codes what the problem is. So it might be too many words in a sentence is yellow, passive phrasing is purple. So you can go through and...
How fantastic.
Yeah.
Okay, so paste in something you're working on and edit away and put it in there, and as again, then you can put it through the lens of 5 of your consumers that's in your target audience. So here's 2 examples. So here's reading grade 12. So you can see there's a lot of words, there's a lot of probably more higher level words that we might look at and go, oh no, that sounds really great, I'm happy with that. But when we look at grade 7, can you see the difference? We've really come down to short and succinct, punchy. That's more where they're saying the target area is between grade 6 and grade 8. It'll do all the work for you. So I want you guys to have a go at this. Work in pairs. It's always fun to have a little bit of, you know, interactivity. I want you to have a go at changing these words that we would often use in medical jargon into plain language. So have a go. We're just going to do this for a couple of minutes. What could you use instead of the word common? Because we use that all the time, don't we? Common cold, common this. Yeah? What words could you use instead of? So have a go at doing that. Just pair up and we'll come back to the grand group in a second. Alrighty. Let's see what we've got for common. What have we got over here for common? Actually, we'll go to Kirsten because she was so challenged by common. What did you have for common?
Rebecca and I thought maybe usual.
Usual? Anyone else got anything different from usual?
Frequent.
Frequent? Mostly?
Or you could drop the common, like if you're talking about common cold, you could just talk about the cold virus.
Okay, nice.
Like that.
So give it context.
The specific thing and just drop the common out.
Beautiful. Nice.
So we said plain or simple.
Plain or simple? What about the PHN? What they? Frequent? All right. What about avoid?
I thought maybe don't.
Don't?
Avoid sugar, don't eat sugar.
Okay. Miss?
Stop or ignore.
Stop or ignore?
We talked about when you're talking to patients is like almost a passive aggressive way of addressing something. Yeah. So
It is.
You could actually reframe the whole thing.
Great.
Talk about what you want them to do.
Perfect. Perfect. So don't is very directive and it can actually meet with a lot of resistance and pushback. So a way if you wanted to engage behaviour is to talk about what they're going to gain, yeah? So it's always good to do it on that positive note of reframing.
I think skip and miss.
Skip and miss. All right. What about chronic? What did you two rat bags over here say? Chronic.
What do I think for chronic? Long term.
Okay. What about you guys? Ongoing long term.
Ongoing long term, or you could talk about their specific condition. So most people, if you're
Great.
talking to them about chronic disease, they don't think they have a chronic disease. So you could talk about your asthma or your pain in your leg.
Yeah,
or
great.
whatever context.
So many people, when we used to send out your diabetes, I'd go, I haven't got diabetes. Last time I had my HbA1c checked, my doctor said I don't have diabetes anymore, so I don't have diabetes anymore. It's really important, isn't it, to see their understanding. What about for you guys? Same? Yeah. All right, what about adequate? Okay. Anyone? Enough? Anything else? What about monitor? Check, great. Watch. Same.
Being seen as negative as well.
What's that? Watch. Watch can be evaluative, can't it? It can mean that I'm watching over you. It's like assessment. Assessment can be a bit like that too, can't it? What about referral? Send. Share. Are you saying something else? C. I thought you were saying seek. I'm going seek. C. I get it. Cardiac.
Yeah.
Anyone got anything else apart from heart? No? All right. So these are the ones that they came up with. For example, condition how you feel. Avoid, do not, or do use. Yeah, it's the positive reframe's better, isn't it? So instead of do not, I would rather the use, because again it comes on to what they're going to gain. So use or da 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 da. So instead of do not, I don't know, what's a do not take with alcohol? Take with water or something like that would be better, wouldn't it? So giving them the positive rather than the negative. Chronic, long-term, lifelong, adequate's enough, watch out for. Sounds a bit fearful, I think. Referral, asked to see another health professional. Again, I think that sounds a bit too high level. C might be just enough, huh? And cardiac heart. So they're the really great resources that are part of that health literacy online platform that I was talking about before that you can step through, particularly if you want to do it as part of induction processes for new staff, particularly working in projects like this. There's a really high need for chronic disease management as well. You know, there's always the talk around, you know, people being compliant and non-compliant. Often it's the practitioner that's working for them that's creating that, so it's important. 2 words, information and communication, are often used interchangeably. As I said before, the information is just the giving out. So you can tell me all the reasons why to have my cervical screening test. You can give me all the brochures. You can talk about all the things really bad that's going to happen to me if I'm not going to have it. Communication is actually getting me to do it. That's the difference, isn't it? So I can have the literacy. Can you remember how many people, 60% wasn't it, haven't got the literacy to understand or interpret the information given to them? But what about me? 50% of my behaviour is actually driven by knowing. The other 50% is you communicating and getting through to me to see that I actually want to have it done. So how are we going to do that? What's our ideas around how we can convert someone who really you can see there's either that fear or there's been that excuses coming up on why they haven't had things done. What kind of ways do you use your communication skills and styles at the moment to try and help them go from not having their cervical screening done to then eventually going and having it? We heard from you before you have multiple visits with them. What's essential to that?
I think not having in your head, I want to do that pap smear.
Yes, get your agenda off.
Needs that pap smear. Yet not sitting there thinking, I have to get this done by the end of this visit. You know?
Yes.
So just letting it unfold more natural communication.
Great.
And maybe talking more about what are their barriers. And not saying it in those words either.
No.
But, you know, finding out what it is that's stopping them from wanting to do it. Because, as you said, it's usually not that it's not
don't know.
That they don't know.
Yes.
There's a whole other reason why they're not having it done.
Yes.
So helping to get to that first before you even think about what your end product is.
That's right. So drop the agenda.
Yeah, drop the agenda.
This does not need to happen today. It can happen over multiple visits. And then it's all about unravelling what's really holding a person back.
But sometimes it's before they even make the appointment. Like once they've made the appointment, not all the time, but that can be the easy part. Once they've actually committed,
Yes.
you know, there may be issues that you do have to space it over multiple appointments, but getting them to make the appointment.
Correct.
So
Yes.
I send out reminder letters, I do outreach clinics, and so to go to an outreach clinic, well, I want women to be there. I don't want to go just for one woman, but I also don't want to cancel her because I know I've been chasing her for a while too. So I might send text messages to people in that catchment. I might even pick up the phone sometimes if I've got time and cold call. And a lot of the time I'm just leaving a message, just phone me. But
Tell me what you say in that message. What kind of message would you leave?
I say, this is just a a courtesy call
Yeah.
from Amanda. Just a reminder that I don't actually say they're overdue.
Yep.
I just say I've got a clinic happening in Cobden next Monday. If you would like an appointment, phone me back or phone reception.
Love to see you. Be great to see you. That kind of,
Yep.
rather than the shaming part of you're overdue is really key here, and that's around again that positive language, isn't it? That reframe. Because sometimes that can be a bit embarrassing, can't it? We've got to think about all the reasons why people often, that shame, all those reasons.
Actually connect.
Yeah.
And I say who it is, and you can hear like,
Yes, they know.
and you're really looking forward to hearing from me, aren't you? So I sort of soften it up.
Beautiful.
But they all have, I'm so sorry, and as simple as that, doesn't matter. That doesn't matter. I'm just letting you know I have got a clinic in Cobden, and if you want to come, can I make the appointment now, or when it suits? I'm just letting you know.
So I'm hearing accessible.
Yep.
I've got appointments available.
Yep.
I'm hearing I'd like to see you,
Yep.
and let's forget about the rest of
I
it.
say you're here now.
Yeah.
So it doesn't
Let's
matter.
do it.
Yeah. And I say, it was my kids that finally said, when are you going to get rid of all of those off the fridge, or here's another one of those letters.
Yes.
Yeah.
What about for you?
Similar. I think, it's connecting and getting to know the patient. And
So is.
So the more we have to do with patients or clients or women, the better rapport that we get. So some of our clients through care planning through the clinic, they might be coming in for other reasons, and their overall health is assessed, and then you gently work through that process, and then work with them until they're comfortable to perhaps go the next step and make that appointment.
Fantastic. Love you.
We've included in all our 45-year-old health assessments. We do a 48-year-old diabetes check, all included in that. It's not just looking at the diabetes. So we're talking about it, encouraging it all the time. All our gestational diabetes and all on care plans and things like that. So it's just become a common denominator within the clinic.
Great. The more we can normalise it, it's same like that bowel screening, isn't it? Taking it out of the package. This is what's inside the package. This is a normal process that happens to everyone, not just you. We're not just targeting you. It's often seen as that fear as well, isn't it? What's going to happen? What if they tell me something come back as a result, and now it's created something bigger than been hurt? I'd rather not know. All of those sorts of things can sit there, but if we put it throughout all our processes that they're getting prompted and nudged no matter when they come in as an opportunity, because they'll walk through our door at some stage. 86.6% of the community come through our doors of their own free will at some stage across the course of the year. So using things like top bar and those prompts and nudges, so it's starting from the whole team, that not only the doctor's having that conversation, but the nurse is also having that conversation as well, whether it's preventative stuff in your health assessments, whether it's your chronic disease management. All of those are really super important. Influenza, as I said, they'll come in for that maybe. They might go for a travel vax. Any way that you can make it really visible so that that conversation's normalised and is just part of your staffing's lens on what we're looking for, and they're not scared to have that discussion. That's the other thing. Some people go, I don't feel comfortable about having that discussion.
They also, on the other side, they say, I didn't realise that. Right when you were saying, we've introduced immunisation, everything right through. The 50-year-olds didn't realise that, they can have the shingles vaccine, but it's available, it's advised from 60 and it's available from 70. So you're starting to introduce the ongoing talking at an early age, so it just becomes, and then the next time you come, you do go over the same thing with them, but you're just reinforcing that it's a total look at holistic care.
Awesome.
And that's what I think they appreciate. Don't you?
I agree. How I frame it is similar to someone was talking about the servicing, I think it was you, servicing your car, and now we want to do that for you as well. The prevention check in your health assessment, having a look at all the social impacts in how we can best support you to keep you fit and well. You know, the 40 to 49 age group that you're targeting is fantastic that you're actually getting people in there. That's often really hard to get that target audience to actually take time off work and, you know, make time, isn't it, and see it as a priority.
What we do, we're a bit naughty, not a bit naughty, but we, when they come in for their cervical screening test, we look at when they've had their cholesterol done, when they've had their weight done, when they've had how about you come back and see us next 45-year-old?
That's a fantastic tip. So did everyone hear that? When they've got a cervical screen patient in, they're starting to look for when they've last had bloods done and then booking them in there and then, yeah?
Yeah, and most of them come back, don't they? They would love it. Yeah.
When we had, we ended up having like a thinking party, and we invited key stakeholders around the Geelong region, and we also invited community members, people who we knew were frequent attendees to our clinic, but you know, they had lots of different reasons for coming quite frequently. So we invited them to come around and have a bit of a think tank on how we could improve things from their end as a consumer. One of the things they said is, instead of us having to go back to the front desk and to stand there when they're trying to check people in and then we've got to pay, by the time I've seen the line, I kind of go, oh, I can't be bothered standing here now and making an appointment. So one of the suggestions was that if you had a bit of paper that you could tick your preferences on what days and times suit you for appointments, and then someone made the appointment, and if it didn't work for you, then you could change it. You could ring back and change it. But it just meant you just dropped that on your way out, and it meant patients were rebooked in. They got an automated text message saying you've been booked in for next week, 3 weeks' time, 4 weeks' time, but it didn't mean that they had to stand in line, have the payment discussion and rebook. So whatever way you can streamline and take that workload out for them, or if it's you, often what I used to do when I had a patient in front of me, I'd just book them into my appointment schedule myself. So they didn't have to stand out in front of the desk. So it just depends on how your practice actually operates and what works best. About you, Jo?
I guess we're fortunate we're running women's wellness clinics these days, and so we've developed a special group of women GPs that will see women with specific issues, and we've got information around that.
Unreal.
Is one thing. Another thing along that challenging people though is sometimes we'll get women in and say, can you take me off your recall reminders? I find it, I don't want those letters or those SMSs. So if I can talk to them and then obviously say, tell me more about that for you.
Awesome.
Because if you can work out that actually that re-traumatises them,
yes,
then you can work out a deal more often than not that you can communicate with them in some other way.
That's brilliant.
And, you know, it might be a few phone calls where you nut out how this process can work for them.
Yes.
But, you know, and then sometimes it takes 3 phone calls, but then you'll get them in the door.
Perfect.
And then we'll say, you don't have to think about that, but what about if we give you a call rather than a letter or something?
Unreal.
Like that.
So it's working with that client in partnership, isn't it? And asking them what's going to work for them. Yeah, don't send me a letter. I don't even go to the letterbox for a start. Don't send me one. No point. Send me a text. If I'm ready for it, yeah, I might answer it or I might do something about it, but sometimes I'll ignore that too, depending on the day. Face-to-face really has quite an impact for me. And I know with the chronic disease clients who weren't coming and having reviews or timely care, that's how I flag them on our appointment schedule as well. And the flagging to the team was the reception team would go and find the nurse to then have that confidential discussion with the client face-to-face. Because it's really important that we think about how each person likes to be engaged. And if you're someone who is that human-to-human approach, that's going to sit right there, isn't it? And it's going to mean that I'm going to have a conversation. Jo's going to have an opportunity to explore that a bit deeper and find that root cause and what's holding someone back, which we can't necessarily get to with letters and phone calls to the depth of what you can with that humanised approach.
We also have a great nurse survival screening provider who offers an alternative. Sometimes women just want to see their GP, but blood pressure and medication.
Yes.
But it gives them a new, fresh face, sensitive, caring person to see separately for cervical screening.
Skilled hands, I say. Skilled hands is who I want to see. Anyone with skill. Usually female and a nurse. Anything to add to that? And what about for you?
I think the starting things young to help normalise it is a good
Yes.
thing. Like when we've been talking about that, I've been thinking about my twins. They've gone to the dentist with their older brother since they were in the pram, and now my daughter's been counting down the days to the dentist appointment today. So they're not frightened. They actually asked me they were asking me for their flu shot. So, and they're not little children, I promise. It's part of their
Normalised, isn't it? Yes. So there's different things to that though, isn't there? So you've said from really young Dot. So I'm going to give you the other side of that. I think it was grade 5 or grade 6. They had a women's and children come to school, fancy, get your show bag. They're talking about, getting your period and growing boobs and all that kind of stuff. And they thought they did a great job, and I thought they did a great job. And then we get in the car and said, so is there anything else you'd like to know or talk about? And she goes, if we never talk about that ever again, that will be a good day for me. So there is always those people that go, I would have much preferred not to know any of that. Yeah, please don't talk about that ever again, Mum. Versus the curious kid, which is my boy, who goes, yeah, my goodness, can I ask questions about that? And I want to be really involved in that. So it's around, isn't it, hitting our target audience. Pick your audience. If we never talk about that again, that's a good day. So I always have her in my head. What about you, Gabby? What about you guys? Oh, you were out in the room.
Yes.
We just talked about what communication styles and tips and tricks you might already utilise for people who aren't necessarily engaging and coming in and having, cervical screening done.
Back when I was practice nursing, I guess I would get them when I had them in the room.
Yeah.
Just absolutely.
Humanised.
Look at their file, see what they need, and just have that conversation.
And I think it's around not spamming out. I think earlier on in Rivka's session we were talking about having the strategy of putting a note on people's computer screens.
Yeah.
It's good for a bit, isn't it? And then everyone spams it out. Then you've got to move it and go, instead of down here on the screen, we've got to put it over there on the screen. Because our brain automatically does that. It starts to spam out normal, which is why you need to do your nudging techniques, particularly for busy practitioners, in lots of different ways and styles. Same thing with your consumers as well. Are we making sure we're doing follow-up text messages to remind them they've got an appointment, all of those kind of things? And do they actually even want that? It's a really important thing, isn't it? Because that can actually put them off. With our dentist, our reminder and recall was about a dentition that my son had to go and have checked, and I was away, and my husband rang me and said, oh, Harrison needs to go and get his dentures checked. Now, I don't think so. Yes, but it's around that language again, isn't it? Around a reminder and recall just dropping out of the system and churning out a letter. How can we make sure that happens? But then they used to always give us an annoying phone call, and I don't want an annoying phone call with this sing-song voice. We're really looking forward to seeing you next week, and da-da. And the conversation would go for 5 minutes before I even had a chance to say, I know, see ya. Just send me a text. So again, we've got to think about those sorts of things, don't we, when we're looking at who we're communicating with.
I think too, if you misjudge how to contact that person, and your follow-up thing is acknowledging that you have perhaps not overstepped the mark, but acknowledging that that patient doesn't want that doing, and admitting that, and saying to them. An example was I had a really bad non-attender who was very chronically, clinically quite unwell, and she brought her sister in one day, and she was sitting in the waiting room, and I just said to her, oh, Mary, could I just see you in my room for a moment? And I approached her about having her renal function and everything done. You know, it was important that we keep up with that. She said, yeah, I'll make an appointment when I'm ready, but went out and put in a complaint that she didn't come into this room, into this clinic to be harassed.
Super important, isn't it?
And I sort of thought, oh, now how am I going to get this done, you know? But it was, yeah.
Definitely the approach and around that timeliness, isn't it?
She just wasn't ready that day. She has since been back, but I just called her on a bad day.
Yeah, and we go in with this, right, I've got this agenda and I want to make sure that everything's done for my patient, which is awesome. That's around duty of care and being really, giving great service, isn't it? But it is using that intuitiveness that comes with the timeliness to present this, isn't it? So it's around asking permission, isn't it? Permission on when. Of course you did.
And not sort of saying, hey, can you just make an appointment on your way out?
Yeah, but a key learning was maybe not every time, yeah, because that's our agenda, isn't it? Let's get this all ticked off. So when we look at communication, only a small portion is this words that we're using. Have a look at how much is our body language. It speaks volumes, and that's what we don't get in terms of nuances with the written word in letter form. You know, how many text messages get misinterpreted because it doesn't have the subtleties of that body language and that delivery. Tone and intonation, wow, that can make a big difference as well. Often when we're rushing, sometimes our tonality can match the rushing but can come off as quite short as well. So we've got to make sure that we have all context when we're delivering things as well. How is it that I can explain something in a way that you're not feeling judged? You're not feeling patronised? You don't feel like I'm telling you what to do? All of those key things are really important when we want to drive behaviour. Because I often hear about, you know, people say, I haven't got compliant patients. What does that even mean? Yeah, they're not doing everything you want them to do, but what about what they want to do? What's really important for them? That would be my first question. What's really important for you moving forward? That gives you a good lens on what your talking points are going to be moving forward. If you want to get that person engaged with you, it's all about that relationship, isn't it?
Then there's that blue line of duty of care too, isn't there? Because
yes,
sometimes you will find patients with low literacy, they don't want to do any of that care at all.
Yes.
But our duty of care is to try and somehow work to inform them so they understand why they need to have that care.
Sure. So it's around using that very first component of this workshop, isn't it? To make sure the messaging is understood by them. That's 50%. And the other bit is that relationship that they have with their practitioner. And fortunately, nurses are seen as trusted professionals. So we already have that in the community, and also perceive that we've got a lot of time on our hands as well, huh? Yeah. So they go, well, the nurse has got time for that, but the doctor doesn't. But that's in our court, really, isn't it? It doesn't matter that you haven't been in the toilet and you haven't had your lunch break. Doesn't matter. But what their perception is that you will hear them out and you'll assist them and you'll interpret that jargon that they might have got from their specialist, or they got from their pathologist, or they got from multiple different things, like, you know, as I said, mum's pieces of the puzzles don't come together. The nurse is seen to be the one that would be able to navigate that system for them, which is a bonus. So yes, we definitely want to give the literacy at the right level. What do we need? If we're not getting that information through, that communication is going to be the key, isn't it? And getting through the next level. So the McKinsey report demonstrates effective communication between team members as an effective hospital strategy. So it's not just me having this conversation face-to-face with you, it's about imparting to the whole broader team around what it is that client wants to work on and what they want for themselves moving forward. So we want to use the client's language. That'll give you a really good indication on what words to use, and particularly reflecting back to them. It's really important that when a client explains to you, particularly around their barriers for coming, that you can reflect back to them what you're hearing. Why do you think that's important, that you reflect back? Not that just you hear it and you nod, reflecting back. Why is that important?
You're acknowledging that you understand.
Yep. And it also gives you an opportunity to clarify if you got it wrong. They might go, no, I didn't mean it like that. What I meant was. Excellent. Now we're both on the same page. So we know there's 70% more uptake when we have kinesthetic learning, which is why teach-back's a really important tool. So, when you're now doing that self-screening, I'm sure that you want them to demonstrate to you what they understood of your instructions, or else it really makes it hard again if you've got to repeat the procedure, does it not, to get them engaged back in the process. I tried that last time and it didn't work and it came back and I had to repeat it again, or etc. So how can you make sure that they understood what was required of them? When you're able to, and as often as you can, use visual tools. That's why those cartoons are really cool. Graphs, charts, any kind of picture, pain score faces, those sorts of things, that's why they're out there. Have visuals, pictures, graphs, maps, charts, 3D models. Everyone got a 3D model in their women's clinics on what bits look like what normally. And demonstrations and gestures. Patient interpreted information sheets, and obviously putting them off to the industry sites. Now, is anyone familiar with GoShare? Has anyone heard of that? Yep, there's a few nods. So again, it's around having health literacy advice that's given from the right information from the right online resources, because Dr. Google can send them to all sorts of places, isn't it? How many people use Dr. Google? All of them, before they get there, as a self-diagnosis piece to find out further information. But how can we make sure that we're giving them the right information? And what's cool about it as well is, particularly, they have patients explaining their journey. So there's a bowel screening one on there as well, of a patient talking about when they got their kit and how to use it, etc. We also want to make sure that we're not judging. We're using a non-judgmental approach. So I just want to ask you guys, how do we judge? How does that show up? Questioning, the style of questioning. How else? That body language says it so much more than the words that we use, because your words can be kind and friendly, but if this isn't matching, it can come off completely different, can't it? We can have two people standing side by side, and one that's coming from that authentic, genuine space versus someone that's saying, I'm just saying, but I don't believe it. And they can see it a million miles away, can't they? Particularly around sensitive issues like this, if your words do not match and come from that authentic space, they'll go, not sharing anything with you about my assault or what's happened to me at other pap smear occasions of service. So don't make assumptions. We're all so different, aren't we? And we all come from such different backgrounds and so many different walks of life and so many different experiences. So just because I do it this way, don't assume that everyone likes the same, yeah? So it's always good to use your questioning style. And your active listening. So active listening, I just want to have a conversation around that. What do people understand when I mean that? What do you think that means?
Being connected and, using those where you sit and look at someone and you take the time to listen. I think a lot of feedback we have got over the years since we've gone digital is that the doctors don't look at them, they don't listen to them because they sit at the computer and say, yeah. And I know when we do, like especially when I do women's clinics, I try not to use my computer apart from print out pathology.
Excellent.
Try and sit and talk to them and take notes like this.
Excellent.
To try and really connect.
It's a really big thing that we're using our computers just so much more, but it's such a disconnect. Because if you're typing on your computer, your brain actually can't do two things. Okay? So you can't actually actively listen and hear everything I say. You're going to drop out of that conversation as your brain focuses in on what you're typing. So just be mindful of that. So if we can use a piece of paper and dot point some key components, but the way you demonstrate your active listening is by the way you reflect back. I hear you just said. It sounds like you are. Yes? Those kind of ways of framing, they go, she gets me. And once you know that someone gets you, what are you more likely to do? Share even more. And that's what we really want to do, particularly around these under-screened women, isn't it? We really want to connect, dig deep, and build that relationship to make sure that they feel like we're actually getting listened to. There is nothing worse than going somewhere and not feeling like you've been listened to. There's nothing worse. I've taken time out of my day and my schedule. It's taken me how long to book you in? It's all around sequence and timing. I've booked the time, and if I don't feel like you've listened to me and heard me, it's going to really upset me, isn't it? So I'm less likely to reconnect back into that service again. So they're just really key, subtle things. Encourage people to ask questions. Health assessments particularly, it can be quite a tick and flick exercise, can't it? So it's a way we get that information out, have a conversation with people, and then obviously get those questions answered, but allow them open-ended questions, really important. Greet people, obviously, with a warm smile, eye contact, and a welcoming attitude. Now, hopefully you can see this. Maybe we'll turn down the lights. Is that going to affect you, Gary? Oh, you might not be able to hear it, but it is very funny. We like a bit of humour. Oh, play. You meant to play.
Well, sometimes doctors make mistakes. Anna, you have to try twice as hard to fix them. Are you using your inhaler?
All the time. Go through one a week.
You sure you're using it right?
Do I look like an idiot?
No. Why don't you show me how your inhaler works?
Jerk.
Don't you love it? So we assume that people have taken in what it is that we've instructed them. There's obviously a gap if she's going through an inhaler once a week. When I saw this, oh, it made me laugh. I just went, it's such an assumption, isn't it, that we assume that the information that we've passed. Yeah, I was chuckling away. Woo, 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 woo. Because it just, how many times have we gone, something's missing here. This doesn't add up. One inhaler a week? I don't think so, yeah? So there's got to be a reason to use our teach back. So a way of checking and understanding, stating in their own words what's required of them. So let's think of that self-test or self-assessment. What kind of words do you use when you're explaining it? Who's using it all the time? If I, yep. You?
We've only done a couple because it's not, because of the criteria, it's not easy to use all the time.
Okay.
We've got to fit the criteria. But yeah.
There's times when I would have liked to have used it.
So tell me, what's your way of demonstrating what they've got to do? What's your style?
So we just sort of say, there's another alternative and explain it's you taking the procedure and you have to take a swab, like if you insert a tampon. We show them, I get out the swab stick and show them how far they just need to gently insert it.
Yes.
And explain you need to go, it's easier perhaps, they can go into the toilet and do it, or they can go into the, where the couch is and lay on the bed and do it, and we're just in the room next to them if they need any assistance or help, how to put once they've done it, what they do with that tube, and explaining it's trying to take some of the cells or some of the secretions and cells from the top of the cervix or near the cervix, the top of the vagina, so we can get a sample to see if they have HPV.
So do you have like a sample one that you've got that you pull out and you can show them or break it open, so there's that kinesthetic learning? But do you get them to have a go before they using that same one? So you go, yep. Yeah, same thing, same. What about you girls? Haven't had to do it yet?
I've done vagina swabs in the same sort of way, so I haven't done that, but
Yeah.
we used to do self-collect vagina swabs.
Yes.
And, or even just for MSUs, it's amazing how many people don't know.
Correct.
How to actually take in proper MSUs, you know. They usually just, someone's given the jar as it goes in the toilet. And, you
There's
know,
an assumption. And what about the number twos? When you get one of them, you go, that's kind of, there's that assumption because we know what's expected that they're going to know, and particularly something like an MSU, which we might see so frequently. But if they've never done one, what do they know what to do?
Like years ago, I worked in radiology and the gentleman had to use it as part of the examination. No one had said to him, undo the suppository from the aluminium foil. So we inserted it that way.
Or people put suppositories in the wrong orifice.
Yeah, yeah. And it's all real stuff, isn't it? But again, we have that assumption because we know that they're going to know. So if you can have a sample that you can pull apart, you show them, but get them to teach it back to you on what steps they need to do. This is what teach back is. And you can use it such across the spectrum, but my most important piece is that you use it often. Don't make that assumption that people know what to do. You know, we used to have blood pressure monitors that we used to send home with clients, and how many phone calls that we would get post that from people going, when I bent my elbow, this thing blew off, now I've got to come back, and you know, or they might have come back the next day and it's around their wrist, and that's how long it's been taking their blood pressure down in their wrist for. But all those kind of things, you need to kind of get them to show you what they just understood from your words.
Like doing a compression bandage on or something, and you just assume that the patient would take it off if it was too tight.
Yes.
Sometimes they don't. They come back the next day and their arm's swollen, saying, we had an elderly lady, she clearly didn't understand us. We said to her, please take this off tonight. She left it on and came back the next day, and her arm was quite swollen and her fingers were quite swollen. I was like, oh.
So a way around that would be, so we've just had a discussion about what steps are going to be now post this procedure. Tell me what you might do next. And so get them to explain what they're going to do at what time when they leave your four walls over the next 24 hours or however long it is. You're really going to see the gaps in what they heard, understood, and then you know what they're going to go home and do, don't you? So it's really important to keep this really in your mind, getting that teach back time, taking the time to do it. So show me method, and we've learnt like that, have we not? Yeah? I remember when I was in intensive care and everyone used to be out, you know, you've got to do your CVP readings, and they'd have this great big rope with fluid in it. And they'd go, see? And I go, nah, how did you get that to stay in there and there? All you'd seem to do was this, and I do it, and it's over there, the fluid, and it's over there, and I feel like I'm doing exactly the same thing. And they're like, oh, well, it's really easy, because they've been doing it for years. You do this, and then you do that, and I go, I still can't, there's half the fluid there, it's half the... It's again, isn't it, someone taking the time and getting me to do it until I understand it and have my own way of getting it just right. So teach back steps, ask your client to demonstrate, use in their own words, and here's a way of framing. I want to be sure that I've explained everything to you clearly. Can you please explain back to me just to make sure that I did? So it puts the onus back on you, so that if they don't get it quite right, they don't feel like, oh, I mucked up. And that's really important, because that can breach trust and rapport, can't it? What will you tell your husband about the changes we made with your blood pressure medicines today? All that sort of stuff that we might do day to day. We've gone over a lot of information, a lot of things you can do to get more exercise in your day. Can you please tell me what we talked about? Again, what did they take away, or were they just nodding, hoping that you would stop talking so they can go home? This is the steps. There's a website up there that you can go and do some teach back training. So www.teachbacktraining.org. So explain, assess, clarify is important, isn't it? Clarify what they interpreted from all those steps that you demonstrated. Because there might be a bit of fear like, oh, I don't know if I'm going to be able to do this as well. So they might only take in a few of the steps because they're too busy in their own head going, oh, I'm unsure. So it'll give you an opportunity to go over some things that there's a little gap there.
So district nurses would use, that would be very beneficial
Oh.
for them, but I could also see that clients wouldn't actually like, some clients, patients wouldn't like to actually get proficient at doing that because it means the district nurse isn't going to come again.
Yes.
So that sort of thing as
I can
well.
have my home back. Because they really don't like that, do they? They find that quite an invasion of their space. As you say, if they know that if I get good at this, she won't have to come, there's a win for all. All right, so there's some online health info. Oh, jeepers, creepers, I don't know what I do. I was very active presser then, wasn't I? I don't know where I've gone to on here.
Right at the beginning.
Oh my goodness me, really. Let's just go into, what's it done there? Postpone. And let's just go over the slides from today. I know. Can you remember all that? Do you want to teach all that back to me? And gobbledygook, hey? It's a good one, isn't it? Gobbledygook. You realise how much we've done, huh? Here? Online information. Where are we going to send them? Are we using a platform like GoShare, or are we going to send them to the industry reputable sites? You know they're going to get on Dr. Google. You know it. You know in your heart of hearts, don't we? So how do we make sure it's reliable? This is what you would teach a client. Is it clear who wrote the material? Is it from an industry website, or is it just a blog post that someone who hasn't got any evidence base has decided to write? Do the authors state their background or perspective? For example, we have an evidence-based organisation, or I am a cancer survivor. Which one is it? It's really important, isn't it? Is it from the Cancer Council, or is it from someone who said, I drank lemon water and fasted for 50 days? Which one? Sites that are not trying to sell a product, super important, isn't it? Again, what kind of due diligence are we imparting here? Is the site Australian? If it's overseas, some of the information may not be relevant, particularly where they can access resources, etc. And is the information up to date? So they should have the last time that it was updated, i.e. is it 2019, or is it back in 1988? Might not have even had computers back then, can't remember. All right, so I want you to have a think about this, and we're just going to do some reporting back to the room. Meet Brenda, she's 48 years of age, she works full time, she's really overdue for her cervical screening. She's had many reminders in the form of a letter and a GP prompting, and she said, yeah, I know. States that she can never remember or finding the right time to book a day off work. What's going to be your strategy? Think about what kind of communication she's had so far. Has that been effective? What kind of things might be important to Brenda that might actually drive her behaviour? She might have the literacy, maybe, that's an assumption on my part, isn't it? Might be really important to find that out. But how might we go, what's our next steps as a clinical team to engage her? She's under-screened, isn't she? Have a natter and get back to me. Just a couple of minutes. What's your strategy? Come on back. What grand ideas have we got? I had quite the innovative idea. What ideas have we got?
I had someone similar to a Brenda, who wasn't as old as that, but she was on a dairy farm.
Yes.
And so where we are, rural location. So she is probably 20, 25 minutes from work. She has 3 children, and she was just like, she's due, if not just a little bit overdue. So I sent her a couple of reminders to suggesting this. Anyway, she acted on the last one, but rang, and her opening line was, "Oh, thank you so much for the reminders. I'm really sorry I haven't." It's okay, how can I help? And she said, "Oh no, I always say, well, when are you in town next?" And she said, "Well, I am in Timbering often, but it's always later in the day, like we're taking the kids into sporting activities and the milk cows." So she's also required in dairy. And I said, "Okay, so what time is that?" She said, "Well, 5 o'clock. That would be the earliest that I drop the kids off then." I said, "Okay, so 5:15, would that be okay?" I finished at 5, but I didn't actually say all that to her. I just said, "Well, when does it suit you? Does that suit now that we've made the time?" And she was there still apologising. I said, "It's okay, that's, you're here now."
Yeah, great.
A negative result meant going back for 5 years. So I don't have to worry about it.
Yeah, but being adaptable and instead of going in with this is our hours and this is, and in her mind she's already got the excuses and the reasons and whatever, you've just opened it up with an open-end question and gone in with...
Come at 4:30 on Tuesday, and that's the one day that she's not in town, and she certainly wouldn't be able to get there.
Correct, yeah. Open-ended question.
And the same for working women at the other end of the day, done like 8:30, so that they can then go off to work, whether that's Warrnambool or wherever. They might be a little bit late, but they're not.
Yeah,
They
right
don't
off the
take a
spectrum.
day off.
No, they don't just take a day off.
Perfect. So being flexible around the timing. I had that you come to my work or you come to my home, but we had a discussion about risk associated with that. But you know, I'm just saying, could be good.
It's not done.
What about you girls?
Well, we thought the girls said that after hours clinic, so
Yeah.
in the evening or
Perfect.
or something, and asking her, does she have any other appointments scheduled? Like maybe she's coming in to get a script for the pill, or can we do it all in one go?
Yeah.
And just get everything done, so she might have time off work, but it might be 2 hours instead of.
That's right. Yes, yes. What about you girls?
We said the out of hours kind of clinics.
Yeah, yeah.
We said mobile clinic, but
I reckon the mobile clinic would be a bit of a goer.
and the GP I used to just bring it on me when I wanted to get another script. And
Go, right, we're on.
I know.
Yeah. So you were like a captive audience that they went, boom, let's do it. While you're here. You know, I think when you work within a medical centre, it's easy enough to kind of pre-plan, but when you're outside of it, sometimes we've got to think about what their barriers are and how we can do a bit of a workaround, and whether that's around having an open question and working around that as a practitioner. It's around getting that trust and rapport back in the room and getting some buy-in again.
But also it's making yourself accessible to their needs as well, because I mean, I don't know how many ladies say, "Oh no, I can't have it done, then I've got to go home and have a shower." They're very conscious of it being
It's going to be a dirty,
you know,
yeah.
I haven't shaved. Really doesn't.
Self-collection.
Self-collection option.
For Brenda.
Yes.
And I think I would have asked her why, because sometimes we just make excuses.
Correct.
But there could actually be another reason why she's
Correct.
ignoring.
She could have done that. Oh, I've heard that you don't have to do till 5 years, so I'm just waiting till my 5th year comes up. But offering her different things might be a good, you know, you can self-collect. She might go, nah, didn't know that. Did you know that you're not really actually in that 5-year system yet? There might be those sorts of opportunities, might there as well. This is a resource that I was talking about earlier on. It's absolutely super duper. Health literacy, Northern New South Wales, LHD, healthnewsouthwales.gov.au. Can you remember that and repeat it back to me? Let's do that teach back thing. So it's a goodie. It's a really fantastic website. You can go on and have a play with their resources. A lot of the information that I imparted today is condensed down from their stuff. Why recreate something that's already so brilliant, that's already available to us? So this is where I got a lot of that information. So using a resource from the e-library, there's plenty of stuff there at your fingertips as well. So you might go and have a look and think, what can I use in terms of my patient weight room? Or I can use this, you know, on our TV displays, all that kind of stuff, a campaign, Women's Health Week, etc., etc. So we are rolling on time here. I would like to know if anyone has any questions before you go and have your lunch. Any questions? Or have we done a lot of chatting and nattering as we went along? Well, thank you very much for having Rivka and I along to Colac.